Hi, I'm Dr. Paul M. Spezia of Advanced Bone and Joint. Today I'm going to talk to you about knee arthritis, when conservative measures fail and it's time for surgery. A little bit about arthritis. This is a normal knee. You can see this is the femur, this is the tibia, this is the articular cartilage and the meniscus, which act as shock absorbers, as well as articular cartilage on the tibia. As arthritis progresses, it's a wear and tear. You can consider it like a tire on an automobile. As you add miles, you lose rubber. As you lose rubber, you increase pain, so to speak, in the case of your knee. So with time, whether or not it's related to previous trauma or genetics, you start to have wear and tear, as illustrated by this area on the inside of the knee on the femur. This is an arthritic area. Now, we try to treat this conservatively as long as possible. The use of Tylenol, weight-bearing exercises that are low impact. We also have people wear braces. We'll have my patients participate in utilizing different anti-inflammatories if Tylenol doesn't work. There's injections you can put in here, steroids into the knee, viscosupplementation, which is synthetic joint fluid. There's also something known as PRP, platelet-rich plasma, which we do as well. When all of these have failed and there's nothing left and the pain keeps you up at night, you can't get out of your car, you can't get out of the back of the store to the front of the store without hanging on to the cart, that's when it's time to consider more aggressive but minimally invasive procedures, such as a total joint arthroplasty. Just to show, as arthritis progresses, it's a time-related situation, and we're talking about osteoarthritis. There's rheumatoid arthritis, there's gouty arthritis, there's lupus. There's many different arthritides, but by far, osteoarthritis is the most common of all. We can see we have progression now with spur formation on the bottom of the tibia and on the femur, and there's loss of joint space as well, medially. And finally, you get to the point where there is arthritic changes in all compartments, both medially, laterally. You have spur formation on both sides of the bone, both on the tibia and the femur. At this stage, there is no conservative measures other than decreasing your weight-bearing status, going to a cane, a walker, or a wheelchair. We do not remove your knee as such, which we actually do, and here's a model of an actual total joint. And this is the total joint that I utilize in my practice. It's actually a resurfacing, such as if you're cutting fine furniture. These are miter cuts that are made with jigs that allow us to have reproducible cuts. And we take a fine layer of bone and that articular cartilage that's damaged off. And then we resurface the knee with these components. The type of prosthesis that I use, I've been using for over 25 years. It's very reproducible, has not gone through any major recalls during that time. So I'm very comfortable using it and in recommending it to my patients. So again, the femur, the tibia, and the kneecap, which is the patella, and they can all be resurfaced. So we'll take this apart in pieces because it is modular. So if you could imagine, when we take this femur, this is made of cobalt chrome. There's no nickel in it in case there's metal allergies. And this is cut, it is placed on the distal femur and is cemented or press fit into position. The tibia is a similar type of fashion, and in between we have this plastic, a special medical grade plastic that we restore the menisci, and these come in different heights. The way this prosthesis is designed, it's designed that we would sacrifice the main ligaments of the knee to allow maximum flexion extension while still giving stability and the ability to what we call of rollback. So the knee has a little bit of pivot, and that's very important in things such as golf, going up and down stairs, and hiking. So that also allows more normal knee kinematics. The kneecap itself, and this is not normally in my practice resurfaced unless there is predominantly kneecap pain. We'll just trim this around the edge and leave your own kneecap alone. However, if it needs replacement, we put again the same type of plastic button. So this is what a total knee looks like. It's done usually as a 1-day or 2-day stay in the hospital, and this is after all conservative measures have failed. The risk of any surgical procedure, bleeding, is less than 1%. Infection, less than 1%. This can be devastating if it happens, so we're very careful at preoperatively treating you with antibiotics if you need them, and always treating you with intraoperative and postoperative antibiotics. We also know that there is a risk of deep venous thrombosis or blood clots. There's medications that we give to you, something as simple as aspirin, to help keep the blood thin, and early motion helps decrease that from happening. Some patients, very rare, will still have pain despite the total knee arthroplasty. That's a very unique indication, and again is less than 1% of the patients. We treat that with blocks. If therapy is not very aggressive, you can get some stiffness in the knee, and sometimes we have to manipulate the knee. But overall, 90% of all total knees that were placed with normal wear and tear in a person of relatively close to ideal body weight are still functioning at 20 years. So it's a very, very well thought out procedure that's been around since 1968. And I've been placing these in patients since 1990. I've seen many evolutions of the total joint, and I feel that this is a good design. It's a very reproducible operation, and in a patient that you follow for long-term care, it is a continuum of care for the knee to keep you active as you age. Now that we know about knee arthritis, I'd like to give you an illustrative case of one of my patients that was treated for end-stage osteoarthrosis. This patient here, both knees, as you can see, show very severe arthritis. There's narrowing of the inside of the knee, or the medial compartment, so they've become bow-legged, actually losing height. Not only is this narrowed, you can see spurs off the tibia and the femur on both knees. On the lateral view, which you see here, there's a flexion deformity, and they could not straighten their knee out. They lacked 10 degrees of full extension. There's a small spur under the kneecap. There's spurs off the back of the femur. There's loss of joint space. So the cushion is gone. Both the cartilage on the femur and the tibia and the menisci are degenerative. So at this stage, the best case for treatment is a total knee arthroplasty. So as continuation of the patient that we just saw, these are the postoperative films. As you can see, the alignment now is much more anatomic, and is actually in slight valgus, which means you're a little bit knock-kneed, and that's how normal alignment is, 5 to 7 degrees. We also see that the space has been restored with the plastic that we discussed. The femur and the tibia have been cemented into place. This is the lateral x-ray showing now full extension of the knee, whereas before it was flexed. So we've taken care of a bowed knee that was flexed, that was painful, now to a knee that has better alignment, has actually lengthened the leg overall, and the patient loved to say, "Doctor, you made me taller." All we did was straighten out a crooked knee. This gets rid of their pain, and now she's ready to go on vacation without pain.